So first, I'd like to thank Angela and Kathy and the organizing committee for inviting me here. It's a real honor. So my talk today, so who am I? I'm a pediatric oncologist. I'm a clinician at the Hospital for Sick Children in Toronto, Canada. And my interest and my discussion today is on the need for psychological research in pediatric oncology. This is a night in Muskoka. It isn't showing up very well, but 2 hours north, it is a beautiful scene of what Canada really is all about. So, in October, Kathy, we had the PSYOP meeting was in Toronto, and there was a pre-meeting that Kathy had organized with the team here. And she asked me to consider the key unmet challenges or clinical needs in children with cancer. Well, one always likes to be profound and very knowledgeable, and so like Darren, we always have second opinions now. And I quickly went to my 5 other pediatric oncology colleagues and asked them this by email. Well, one expects to hear what are the big issues when things about second cancers. We think about fertility issues. We think about the side effects, the toxicities. But my 5 colleagues independently responded psychosocial support services and the needs for the families and the children was our biggest consistent issue in our program. So is it a sense of unmet needs, a sense of inadequacy, perhaps a little bit of both? Certainly, we looked at the anxiety disorder and response to medical procedures that could be a painful and illicit anticipatory anxiety. But I'm going to put much of that behind because there's a great deal of research that has been done in this area, painful procedures and mitigation strategies around that. And as going on, we talked at our conference a little bit about post-traumatic stress disorder. And I think a lot of certainly in a discussion with my colleagues, we've heard that this is an issue, but we didn't know very much about it. So, as a disclaimer, if there's any psychologists in the audience, I wish to say I am not a psychologist. I'm trying to promote you, but it does become conflicting as I go forward, and that'll become self-apparent. So I mentioned that in the past we've certainly done a lot of the research around diagnosis and anxiety and depression. But when it comes to researchers have also recently recognized the similarity of the symptoms of parents and children to post-traumatic stress disorder. And so the hallmarks of that are re-experiencing distressing events, physiological arousal, and efforts to avoid cancer-related experiences. We're all hearing this about our soldiers who are coming back from Afghanistan and Iraq. So what is re-experiencing? Well, it may reveal itself through reenactment play in a child, intense prolonged distress at exposure to reminders, marked physiologic reactions to reminders. So certainly in my practice, do I see this type of thing occurring? And the answer is yes. When we have a child come back in and we want to do something, even mentioning the procedure can result in what we would describe as a temper tantrum, an outburst, a rapid increase in heart rate, a lot of emotion. How about avoidance in a family? And how could they have forgotten that appointment? We have 9 people here organized around the table and they haven't shown up. Avoiding of external reminders that will trigger distressing memories. The family that would normally drive right by the hospital to get to their point, but literally cannot drive by the hospital, will drive 2 miles away from that route, alternatively to avoid coming by us. Arousal, behavior, irritability, aggression, problems concentrating, and sleep disturbance. So certainly these symptoms are very reminiscent in all of the children who go through chronic illness. So there's post-traumatic stress disorder and a condition that is post-traumatic stress symptoms that add up, and they're prompted by ongoing trauma, such as the diagnosis, seeing your child in pain, hospitalizations, adverse toxicity, deaths of other children, recurrence of the disease. So the studies suggest these trauma-related experiences by families, common experience, may interfere with communication with the family and the treating team. And in some ways, this is reflecting on an experience that I have, a paradox, where families 15 years, 20 years later can tell me verbatim, using my phrases that I typically use, exactly what I said to them. But they didn't necessarily understand what I was saying through the time because they're processing, their thoughts are on other matters. At the parent conference that we had in Toronto, one of the families that I had asked one of my families to speak, and there was rather a breathtaking moment in it when she got up and said, because she was talking about research, I didn't understand what Dr. Grant's research was about until my child relapsed. And then she began to read and intensively understand what the research was all about. Because I'd asked her to do this consent form in the middle of all her trauma. How was she going to process all the things that I was saying to her? So when researchers approach parents during their child's treatment, symptoms of PTSS are common. And Kazak, who's down in Philadelphia, has been working on this, and she feels that all but one parent in her study acknowledged one symptom, and 2/3 of moms and half of the dads expressed moderate to severe range of post-traumatic stress syndrome symptoms on scales utilized. And further, Kazak's study demonstrated the symptoms were more common in the group of parents whose child was receiving therapy than in the group of aftercare or long-term follow-up. She has tools such as the PAT, which is now widely used in many institutions to assess post-traumatic stress. But it would appear from the literature that most parents, in fact, recover, and the overall prevalence of post-traumatic stress disorder in parents of children who had cancer is not higher than the population at large. And work by Gersberg examined parents of children with cancer and compared the group to a healthy control group, finding less post-traumatic stress disorder in symptoms than healthy controls. So what am I saying to you folks? I'm saying that we were told to focus on post-traumatic stress disorder, but the data says post-traumatic stress disorder is not what occurs in parents post-cancer therapy of their children. Well, something sure is going on, and it just is a matter of definitions. As I read this literature, it comes down to definitions, and PTSD has a definition, and so many of the symptomatologies are very similar, but it doesn't meet the full definition. So there is also another problem with much of the literature, is that it would compare a treatment group, as Dr. Kazak had done, with the aftercare group, failing to take into consideration healthy control groups like Gersberg did. And then there's this other study that may be more reflective, took on juvenile rheumatoid arthritis as well as healthy controls. And what they found was they compared them, and then the ages between 1.5 and 5 years of age in the JRA group had a higher aggressive behavior as part of externalizing, where the 6 to 18 significantly higher scores than the JRA and attention problems, but not in anxiety or depressed measures. So this discrepancy, are the studies demonstrating these findings reflecting PTSS, or is it the parent is experiencing multiple traumatic stressors, except when there's recurrence, when PTSD is well recognized? So the next paragraph is actually my take-home message. A concept has arisen of focusing on the little T's, the little traumas that sequentially distress the child and family and may be more important to the family in a preemptive approach. In other words, what the child is going through, what the parent is going through sequentially results in the symptoms appearing to be similar to PTSD. And in the survivors, do they see PTSD? So 20% of young adults who survived cancer met the full diagnosis of PTSD. Of them, the remaining showed some symptomatology. But what I found interesting was there was a fourfold greater prevalence of symptoms in the 19 to 40-year-old group compared to the 9 to 18 group. And there's some discussion in regard to this as to the meaning of childhood cancer. Sort of comes home to roost when you're raised in your own family and there's risk to you at that stage. What does this all mean? Risks of heart problems, risks of a shortened life. How will you raise that family? So how do I bring this all back to me and back to my patients? And as I'll talk about one of my cases in a minute, I work a lot on mutations. In fact, one of the parents at the group said, I'm a Dicer family. And it caught me off guard, because that's not my message to them. Everybody is a normal variation, but we're trying to find the cause of that particular cancer and to try and personalize medicine. So personalized medicine is trying to dissect out the cause of that disease so we can target that and treat it more effectively. And if I over-focused on so-called personalized medicine versus focusing on the wonderful chance of survival and great need to make medical therapy easier to go through, is the problem me? Have I depersonalized personalized medicine? So what is the issue? Well, our team was working with a Wilms tumor patient, in fact, a number of them, and the families we were puzzled why there was growing anxiety in the children and parents and the staff around chemotherapy administration of just vincristine weekly. So the children in our clinic at times were being restrained to have their port accessed. So this is, for me, because I'm older, just very, very difficult to believe, because we had many techniques that we developed 25 years ago to do lumbar punctures, for example, in children, without sedation, without Emla cream. In fact, I'm recorded on a videotape doing a lumbar puncture and putting methotrexate into that lumbar puncture to treat a child with leukemia, while the child was actively talking, and actually I had to ask him to stop laughing because he was experiencing distraction therapy. We have techniques. There's no reason to be holding a child down to access their port. He isn't experiencing pain, so why are we doing it? And each time this child was coming in, it was a new trauma. This was a little T that we kept on escalating and escalating until we have a behavior that we then have to refer on to psychological support services. So for our 350 kids in SickKids, we have 4 psychologists. So we don't have enough resources to meet all their needs, so we do have to prioritize. But we aren't using the techniques that we know and we should be using. So the dynamic between the individuals and the external factors need better understanding. And the child and their developmental stage and what they're perceiving and what they're expressing. The parent, their past experiences, we need to get to know them again. The treating team, where is our focus when dealing with a family and child? The cultures that we're one world now. In Toronto, we see people just like London from around the world. What are their thoughts? What are their fears? And most of all, the interventions that are available, it's time to use them. It also highlights why research protocols development needs to consider the little t's the study will cause and consider how they can best be mitigated, not just quality of life assessment of patients, although that helps to pick up the anxiety levels. What are you going to do about it? Are you studying it, or are you going to intervene? So tools already exist to assist in identifying families at greater need of intervention and need to be used at diagnosis for anxiety and depression and throughout the little t's. Parental and treating team response is very much a factor that can influence the response of the child. And more attention to acute trauma, because I think that's probably what we're actually doing with these little t's. Acute trauma needs to be brought in. Kathy asked if I was going to talk about anxiety, because in the end, I think that this is really the issue that we are creating in the families, and how to mitigate the anxiety that the families, you guys, this is what we were hearing back from our parents anyways, maybe you'll disagree, and to decrease the anxiety so that the little t's can be dealt with. And certainly, I look at the pamphlets and books out here. This information is critical. At SickKids, we have good internet services, we have good programs, but there are some wonderful research that tells us what we're doing locally isn't helpful. In other words, you have to tailor it to the actual target. In other words, personalize the education as well. So in conclusion, when it comes down to the study that says parents and children do not have problems at the end of their therapy in the range of post-traumatic stress disorder, what it means is they didn't fit that label, because we know a parent never forgets, and neither does a child, as they have gone through the traumatic event of a child being treated for cancer. The psychological resources need to be better understood for the group as a whole, and research needs to occur in this area. In terms of anxiety, I can say that at SickKids we have, she's going to kill me, Lillian Sung, word searching for Lillian Sung, has just hired a postdoc to begin a project to look at anxiety in our population, to better develop tools that we can actually start to measure the anxiety levels and to then start to intervene earlier at each little t. That's where I'd like to finish off. Certainly for my post-traumatic stress syndrome, this is what I do. I take off down my little road.